Three symptoms, one murmur, one wall. Everything points towards aortic stenosis. By the end of this video, you will know why. I have covered the basics of aortic stenosis in the shorts. Do watch them. Now let us learn aortic stenosis in detail. Let us define aortic stenosis. What is aortic stenosis? Aortic stenosis is a progressive valvular disorder characterized by narrowing of the aortic wall orifice, obstructing blood flow from the left ventricle into the aorta during systole. This creates a chronic pressure overload state, compelling the left ventricle to generate abnormally the high pressure to maintain systemic cardiac output. Over time, the sustained pressure gradient leads to the compensatory hypertrophy and diastolic dysfunction, eventually heart failure if it is left untreated. Now basically the aortic valve has three leaflets and three commissures. These are the leaflets and these are the commissures and one annulus. Now in aortic stenosis, the normal aortic valve gets stenosed, causing the obstruction of blood flow. Key hemodynamic features of aortic stenosis are fixed obstruction causes the outflow of the LV during systole decreases due to the fixed obstruction. The leaflets gets stenosed and cause the obstruction of the blood during the systole. The pressure gradient develops across the aortic valve and the cardiac output is maintained at rest initially. Exercise intolerance occurs as the output fails to rise. Now the classification of aortic stenosis, where the aortic stenosis is classified on the basis of etiology and on the basis of severity. Now first we will see the etiological classification of the aortic stenosis, where aortic stenosis is classified as congenital, degenerative and rheumatic aortic stenosis. Wherein the congenital one, primarily it occurs due to bicuspid aortic valve affecting 1 to 2% of general population, often present in younger patients but can manifest earlier or later depending on the severity and calcification rate. May be associated with coarctation of aorta and other congenital heart defects. The second one is the degenerative, wherein the most common cause of aortic stenosis in developed countries is the degenerative etiology behind the aortic stenosis, typically affecting elderly people, characterized by progressive calcification and fibrosis of the previously normal trileaflet valve. Shares the risk factors like atherosclerosis, hypertension, hyperlipidemia, diabetes, chronic kidney disease, etc. In the rheumatic etiology, where it is the cause of the aortic stenosis, is the consequence of the acute rheumatic fever, which leads to the commissural fusion, leaflet thickening and calcification of the leaflet, often associated with mitral valve involvement also. More prevalent in developing countries and typically affects younger adults. Distinctive fish mouth appearance on echocardiography. Now let us see the severity classification of the aortic stenosis, where the aortic stenosis is classified on the basis of severity as mild aortic stenosis, moderate aortic stenosis and severe aortic stenosis, wherein the valve area in mild is more than 1.5 centimeter square. In moderate it is from 1 to 1.5 and in the severe it is less than 1 centimeter square. The gradient, the mean gradient in mild it is from 20 less than 20 millimeters of Hg. In moderate it is from 20 to 30 millimeters of mercury. In severe it is more than 40 millimeters of mercury. Patients are usually asymptomatic and require monitoring in mild AS. Symptoms may begin to appear with exertion. Close follow-ups are essential in moderate aortic stenosis. Associated with poor prognosis if symptomatic and untreated, intervention is typically indicated in the severe aortic stenosis. The etiology behind the aortic stenosis, where we have seen just now the degenerative calcification, congenital bicuspid valve, and rheumatic heart disease. The most common cause in the patients is the degenerative calcification over the 65 years. Progressive calcium deposition occurs on the walls of the leaflets leading to the stenosis. The risk factors are the same: hypertension, hyperlipidemia, and CKD. In the congenital bicuspid valve, it presents 1 to 2% of the population where the bicuspid valve experience turbulent blood flow. Premature wearing occurs. Symptoms typically emerge in the 4th to 6th decades earlier than degenerative aortic stenosis. The rheumatic heart disease, wherein historically it is a leading cause, now less common in developed countries. Rheumatic aortic stenosis almost always associated with mitral valve disease, commissural fusion, and calcification produce stenosis. Typically 20 to 40 years is the initial for the rheumatic fever. The mnemonic for the etiology is the ABC of aortic stenosis, where A stands for age-related calcification, that is degenerative calcification, B stands for bicuspid valve, and C stands for commissural fusion. Pathophysiology behind the aortic stenosis is the narrowing of the valve occurs due to the pressure gradient. Diastolic dysfunction occurs due to the impaired relaxation with the atrial dependence. Concentric LVS and decompensation occurs as the consequences of the aortic stenosis. The classical triad behind the clinical features is angina, syncope, and dyspnea. The mnemonic for it is SAD, where the angina occurs in 66% of symptomatic patients, caused by mismatch between the oxygen supply and the demand of the body. LVH increases the demand while elevated wall pressure compresses the coronary arteries. Reducing the supply may occur even with angiographically normal coronary arteries. Syncope on exertion, wherein it presents with the 33% of patient, results with fixed cardiac output unable to meet peripheral demands of the blood to the body during the exercise. Peripheral vasodilation during exertion causes systemic hypotension, often preceded by lightheadedness and near syncope. Dyspnea and the heart failure are latest and most common symptoms. Elevated LVs and diastolic pressure transmits backward into the pulmonary circulation, causing exertional dyspnea, orthopnea, or PND. Signals transitions to the decompensated heart failure. Mnemonic for it is SAD, syncope, angina, and dyspnea, that is breathlessness. Let us see the physical examination findings of the aortic stenosis, where the inspection and palpation gives us pulsus parvus e tardus, where the carotid pulse is weak, that is parvus, and delayed, that is tardus. The hallmark for the aortic stenosis, best appreciated by simultaneous palpation of carotid pulse with the auscultation of the apex. Systolic thrill, where the palpebral vibration at the second right intercostal space indicates severe stenosis with high velocity turbulent flow. Sustained apex beat, where the heaving and non-displaced apex beat due to concentric LVS occurs. The blood pressure here is narrow pulse pressure. On auscultation, we have The murmur, that is the ejection systolic murmur, it is a crescendo-decrescendo type of murmur heard at second right intercostal space radiating to the carotid. Intensity peaks later the systole as the severity of aortic stenosis increases. Soft or single S2, the aortic component E2 is soft or absent due to immobile calcified leaflets of the aortic wall. S2 may become single, or paradoxically the splitting of S2 occurs. S4 gallop is also seen, that is the atrial contraction into the stiff hypertrophic ventricle produces S4, a sign of significant LVH and diastolic dysfunction. Now let us see the diagnostic imaging for the aortic stenosis. We will just enumerate the gold standard ones. That is the first one is the transthoracic echocardiography. The second one is the transesophageal echocardiography, and third one is the cardiac catheterization. Others are like ECG, chest X-ray can be done. Now transthoracic echocardiography, where it is a primary diagnostic tool for aortic stenosis. It measures the peak jet velocity, mean pressure gradient, and calculates aortic valve area using the continuity of the equation. Also assesses LV valve thickness, ejection fraction, and diastolic dysfunction. Non-invasive, widely available, and sufficient in most common cases of the aortic stenosis. Transesophageal echocardiography, wherein it is used, that is the TEE images, are the suboptimal or when subvalvular or supravalvular pathology is suspected. Provides superior anatomical detail of the valve apparatus, aortic root, and the ascending aorta, essential for pre-procedure planning in TAVR, indicates the candidates of the aortic stenosis. The cardiac catheterization is reserved for the cases with discordant clinical and echocardiographic findings where the concomitant coronary artery disease may be assessed. Direct measurement of LV aortic pressure gradient provides definitive hemodynamic data. Defining the severity of the aortic stenosis is valve area less than 1 centimeter, gradient more than 40 millimeters of mercury, velocity more than 4 is called as severe aortic stenosis. For the normal aortic, the grading is that is the normal, mild, moderate, severe, and critical. In normal, the aortic valve area is 3 to 4 centimeters square. Gradient is less than 5 and peak velocity is less than 2. In mild, it is 1.5 to 2.5, less than 25 gradient. 2 to 2.9 is the peak jet velocity. In moderate, it is 1 to 1.5 aortic valve area. Mean gradient is 25 to 40 and peak jet velocity is 3 to 3.9. In severe, it is less than 1 centimeter square. The gradient is more than 40 and the peak jet velocity is more than or equal to 4. In critical, it is less than 0.8 centimeter square. Gradient is more than 50 and peak jet velocity is more than 5. Treatment strategies for aortic stenosis, where the management of aortic stenosis transitions from careful observation to the definitive valve replacement. Once symptoms develop, the severe criteria are met. The medical management says primarily supportive aims to manage the symptoms like heart failure with diuretics and controls comorbidities like hypertension with antihypertensive diabetes and other symptoms. It does not halt aortic stenosis progression or replace the diseased valve. Close monitoring is crucial as symptom worsen. Then we have the replacement therapies like Surgical aortic valve replacement, that is SAVR, is done is a traditional open heart procedure involves replacing the diseased valve with mechanical or bioprosthetic valve. Recommended for younger patients like less than 65 to 70 years. For those requiring the cardiac surgeries like CABG, offers excellent long-term durability in these patients. The second one is the transcatheter aortic valve implantation, where it is an invasive procedure delivering a new valve via a catheter. Preferred for intermediate to high risk surgical patients, increasingly considered for low risk individuals. Offers faster recovery, but long-term durability data is still evolving. Conclusion of today's topic is that is the key takeaways is the aortic stenosis is a progressive lethal disease. Once symptomatic, early recognition is paramount. Echocardiography is the gold standard for the diagnosis of the aortic stenosis. The valve replacement like SAVR or CAVR are the only definitive procedures to treat severe symptomatic aortic stenosis. And the mnemonic for aortic stenosis is AS-SAD, where A stands for angina, syncope, S for sudden death, surgical save life, and aortic valve area less than 1 centimeter, and D for dyspnea is the late sign, that is breathlessness. But the classical clinical features are SAD, that is syncope, angina, and dyspnea is the mnemonic for the clinical features of aortic stenosis. Thanks for watching. If you understood today's topic, don't forget to like, share and subscribe to my channel.